On my introduction to lasers is a little bit nice in terms of what really happened. I was at a conference and I saw this box with flashing lights, and I saw a study of 105 toes and found it quite amusing. And I kind of thought, 105 toes as a study to say that something is effective isn't really something that I'd be particularly interested in buying. So I set them a challenge. I wanted to see, did it work? Could it work? Was it a joke? I think my whole thing was, once and for all, I wanted to prove that this whole thing around cold lasers was a load of rubbish. And the company gave me the opportunity to do that. And for me, it was quite interesting because the opposite happened. I found something that does work, something that I'm very excited by, and something that has very much changed the direction of my practice. Anyway, that's me. I'm strange insofar as my path to podiatry wasn't direct. I had 15 years as a Benedictine monk. My primary qualification is a divinity studies, and after that I decided to go into podiatry, and somewhere along the line collected all these letters. I'm going to talk to you this morning about mycosis, something that we all see on a regular basis. And from this study point of view, it's important that when you think about it, you don't just look at it and say, that's mycosis. Because a lot of us will eyeball it, we'll say we recognize it, and we'll presume to treat it on that with some degrees of success, but plenty of degrees of failure. What I'm looking at is something that hopefully in time may come to inform best practice when we have more research and when we get as far as systematic reviews. So what is it? I think we all know what it is, what it refers to. And I think we all have a fair idea of how the whole thing is contracted and spread. One of the problems that we have is fungus is something that's in our environment. You can't get rid of it. We might be able to get rid of the fungus. We might be able to get rid of a lot of the spores, but the endospores that are left cause the biggest part of the problem. So, we've all seen those. The reason I picked this picture is I see this coming into the clinic quite frequently, and they expect me to be able to do something with that and the laser. The laser is very effective. The study that we have done was predicated on 4 treatments. 4 treatments will not fix that. And another interesting thing with that, of the patients, the 500 that we saw, we decided we'd ask them lots of questions, as you do with research, but one of the questions we asked them was about comfort. And you'd be surprised the number of people in Ireland that walk around with things like that in their shoes and end up having days off work. Over the course of the study, 2,570 days were lost from work because of mycosis. And we're stuck at the moment in terms of where does it fit? Is it cosmetic or is it medical? I think if it's taking time out of work, it's probably more medical than cosmetic. So we all know the next bit, the subtypes that it's divided into, and what those subtypes look like. And traditionally, if you look at the literature on laser treatments in terms of mycosis, they would actually say to us that we shouldn't really treat the white superficial, we shouldn't really treat the EO, we should just treat the rest of them. And the reason they do that was because there hasn't been very much research to date on this, and we're just really starting the whole research process. Cardinal mycosis is really something that some of the literature says exists, some of the literature says it doesn't. It's really a case of we're doing something that's different. So how do we fix fungal infections? Traditionally, we have a collection of pills that we can take. We have lots of topical things. And a lot of the topical things are actually quite effective. It's a case of our patients aren't. If they were to use them properly, we might get more efficacy rates. So we fix mycosis with research. And why? Well, really, we have to look at finding viable options for its treatment. And when we look at these options, we need to look for something that we can prove or disprove as an intervention. And then we have to have an exploration of the possibilities that there might be something out there that works. We have to find something that's painless, and something that's time efficient, and something that's non-toxic. And in today's climate, if, like me, you work in private practice, one of the most important things we have to consider is it revenue efficient? So where do we begin with research? We all have degrees, we all know how research works. So the first thing that we did in terms of this study, we had a look to see what was out there for the treatment of the condition. Then we chose an intervention and we did our base study, and we did the base study in keeping with what the manufacturer had said we should do. We charted the effects of the intervention, and from that we developed a more secure protocol and conducted a base study. Then we had the whole bother of getting our protocol approved by ethics, and we had to have a review panel appointed in terms of looking at what we were doing. And then we recruited our subjects. We tended to call them victims. So there's the research process. I don't need to read it. I think we're all fairly okay with it. So how the study was set up. We basically took 500 people, aged between the ages of 19 and 70. All of them had a positive mycology. So this was a positive mycology study. We didn't have a control group because we were treating everybody with real laser, and we were treating everybody that had a positive mycology on test. All of them agreed to keep the protocol. They told us, but occasionally you'd see the odd nail coming in with a glisten of pink, and you'd have to say to him, really, it's not the right thing to do. Everybody kept a diary. The reason we keep diaries on things like this is we're talking about laser, we're talking about an intervention that we're trying to prove, and what we need to know is, are there side effects? Or are there any other adverse events that might not necessarily come into the side effect side of our research? So as I said earlier, it was a positive mycology study, so we didn't have a control group. The study ran on a 4-week intervention period with 7 days between the applications of the treatment, plus or minus a day. So that means everybody on this study, irrespective of the condition of their nail, got 4 interventions. The study ran for 18 months. And we're still doing a little bit of follow-up on that because we still want to reach out a little bit further and see what's going on down the line. So that's the device we used. Is it still flashing? It is. It's timing me, really. It blows up when it's time to finish. So this is the device that we used. It's simple. It's straightforward. You would think that lasers are delicate, but we've dropped these. We've bumped them and banged them, and they still seem to work. I think you've had the same things happen, and they seem to be fine. So pretty robust, pretty strong device. So results. Results and research is something that I really, all my life, as a podiatrist, have had a problem with, because we look at the evidence base, and then we look at statistics, and the statistics and the evidence base don't always add up because there's mismatches, and it's very hard to interpret what's going on. So as clinicians, we really tend to rely on the evidence base. As I said, we sometimes have problems with statistics. These are some of the data capture sheets that we used. So every patient, when they came in, we took a history, we photographed the toe, and we sent all of the photographs out to a lab who basically had some technology that we didn't have. There's technology that you can use from satellites for measuring maps, and they measure rises and falls in the ground. And in order to do this, we needed to know how much of the nail was infected and how much wasn't, because it's a study and we needed to be exact. And fungus isn't obliging enough that it'll grow in a straight line. So the biggest problem we had was, how do you quantify how much is there? So we sent this out to a lab, and they used mapping technology on it to triangulate the amount of fungus that we had on the nail. So the data we gathered from our point of view was quite exact. So this is what happened after 12 weeks. So if you go back and here, and that's what we end up with. Another one. Again, on this one, you can actually see here where we have the measures and things marked on for working out what's what. So this is another one. The reason I picked this one is, if you look here, I don't know if you can quite pick it up, but you'll see that there's actually ridge lines on the nails. And one of the first things that we noticed is, after every intervention, when the patient came back a week later, the nail had actually grown, and you could see a ridge line on the nail. So we kind of referred to this as the event line, and you could actually chart the progress through the lines. And in some respects, then that made our job a wee bit easier, because now we had a straight line. But we still kept the same measurement throughout. Did you put this on? Really? Okay, so 637 toes. The interesting part about this was, when I was talking to Kerry Zhang, who did the original study, they found that the majority of people presenting with fungal infections was men. And we found in Ireland completely the opposite. And England isn't so far away, so I would imagine if we tried to repeat the study here, you would probably find that the women rule the roost. So 320 female toes, 500 great toes, 137 second and other toes, 398 had a previous intervention. So a lot of people had already tried something, and it hadn't worked. 439 had a history of athlete's foot. 61 with no previous fungal history. So our baselines. We looked at 0 to 24% involvement, 25 to 49, 50, 74, 75 to 100. 10% of our patients had the lesser, and they're the percentages for the other groups. Now, at this stage, it is important to remember that all of these patients had 4 treatments, that's all. If we were doing it again, we would actually have this as one study group, probably here as one study group, and this as another study group, because this group here would have benefited from more laser. That's not to say it didn't work. It did work. There was good improvement, but we'll get on to that in a minute. So 12 weeks later, we recalled all of our patients. And these were the results that we had. And from a research point of view, the next statistic is a wee bit annoying, because at 12 weeks, we had already lost 40% of our patients. We gathered more data at 24 weeks, 36 weeks, and 48 weeks. We did a full recall of problem patients at 60, and we did a total recall at 78 weeks. The final results that we got was, at 36 weeks, 60% of the patient group was clear. At 48 weeks, 89% was clear. And on the recall, we had 10% that hadn't resolved. So over the entire period, we would basically say that with the 500 patients that we had over the period, we had 90% effectiveness, even on the patients that had worse nails. So the important thing with any of these presentations, especially when it's research, is I didn't say half the things you think I said. So, questions?
If I could just quickly come in, chaps, before we take any questions beforehand, I was going to introduce
introduce Martin Abrahams from London Laser Clinic and Katrina Waller from Complete Feet. Martin bought her first Lunula in 2012, and if any of you were at the conference in Liverpool last year, did the presentation. Katrina came on board in January and has been over the moon with the success that she's actually had with the equipment. So as well as firing any questions at Robert, if you'd like to also fire anything at Martin and Katrina, we're running a successful laser practice, we'd be more than happy to answer your questions.
Did you denude the nails before you used the laser?
I suppose that's the one mistake I made with this presentation. We didn't tell you the protocol that we used. Every patient that came in, if the nails needed to be debrided, we debrided the nail to a relatively normal thickness. And we did that to all of them. And when they came back at subsequent weeks, if it needed to be debrided, it was debrided again. No, not aggressively, down to a normal thickness, what we would consider to be a normal thickness. I mean, at that stage, you're going to get flaking of the nail anyway, but we took it down to that level. The reason we did that was we needed to have a static measuring point. We needed to be consistent throughout, and we needed to be able to see what was happening. And if we aggressively debrided it, it was going to send our measurements all over the place. So we needed something concrete that we could use to measure from. So we just basically reduced the nail down to a relatively normal thickness, as we would consider.
If the nail's loose, did you trim the loose nail right back and just lasered the exposed nail down?
We tried where possible to keep all of the nails roughly the same length, between sort of 14 and 16 millimeters in length if we could. So we wouldn't trim it right back, we would always leave the nail there as much as possible. That was a decision that we took at the start because we were concerned with the measuring points that we were going to use. And as well as that, it allowed us to actually see nail growth more clearly. Because if we had taken it right back, we wouldn't really see what we were looking for in terms of the research.
Okay, thank you.
Gentleman at the back.
I'm interested, you said you lost, was it 40% at week 12 of your cohort? Two questions relating to that. Your figures you quoted later, were those percentages based on your remaining
No.
60%?
No.
How did you get the figures then if you lost them from the study? And
We
why
didn't
did-
actually
and why
lose
did you
it. We
lose
didn't actually lose them from the study, but in terms of the protocol, they had actually, their nails were now grown. So they still remained in the study to the end of the period, because if they didn't, our statistical baseline would have been wrong. So we had 500 patients at the start, we had 500 patients at the end.
All right,
The fact that their nails had resolved, they still remained in the study because we had to be statistically correct.
But you say you lost them, so they didn't come back for the review at 12 weeks?
No, we had them back for all of the reviews, but
Right.
from
Wasn't
point of view of the resolution of the nail, their nails had resolved at that time. So because we wanted to continue to assess, we needed to have our statistical basis correct. They came back for every appointment that they were scheduled to have.
Okay, just can't understand why you said you lost them.
It's a positive losing
It's a positive
40% as
loss.
opposed to negative losing 40%.
Right.
It's a positive
Okay,
loss.
positive loss, not a
Yeah.
negative loss.
Yeah.
Yes.
And
They're
I
cured.
came in late, so I do apologise, but have you done any follow-up? How far have you followed up your patients?
We
so
followed
far?
up as far as this goes, 18 months.
Right.
And we're now on the end of our recall from there, which isn't part of the study. It's just I'm interested to know.
I'm interested to know as well.
Yeah.
That would be really useful information to
Yeah.
know the recurrence rate.
Yeah.
Yeah.
Because, I mean, like, in the course of the study, I think we had 2 recurrences, I think, in the whole thing.
I think it was up to 48 weeks. I think at the end of
Yeah.
500, it was 10.
See, the problem is, like, you can get rid of, you can treat what's there now, but you can't preempt what's going to happen to the patient in the future.
Totally agree.
And what we need to be able to say is, we managed to allay, cure, fix, whatever you want to call this current fungal event. And then if they reinfect, then what we need to be able to say is that they have gone back to a reservoir, they have reinfected, it isn't the same recurrence of the infection that they had.
No, I agree with you. I think the problem is that patients continue with their habits, they continue with their activities, their social life and all the things that they're used to doing, which is often why they acquire a fungal infection through the course of those activities. The problem I have at the moment is convincing a patient to reinvest a large amount of money on an ongoing basis if reinfection occurs every 2 to 3 years. And those long-term studies will be really interesting to me.
I think with the long-term studies, we are going to see a reinfection rate. I would expect that to happen. But what I'm trying to see is there a tie back to the first event?
Yeah.
I mean, because like you will even see, like in talking to patients within this, you will even see evidence within the study that their parents had it. They haven't lived with their parents since they were 18. Their siblings have it. They haven't lived with their siblings for a number of years. So I mean, in the back of my mind at the moment, I have this question: is there a genetic event going on here? Is there something else going on that we're not seeing yet? So I mean, in doing this, I for myself, in doing this, I have given myself a nightmare, because I have far more questions myself now at the end of this than I had at the start, because I'm thinking more broadly in terms of this, because we're looking at other fungal correlations as well. We're not just looking at something that comes from the Trichophytes species, we're looking beyond that into other dermophatic infections. So.
No, I understand, and you're adding to my nightmares as well. I think there's predispositions and all sorts of factors involved. Thank you for that, though.
All right.
Thank you for the presentation, Robert. As a researcher, one of the key questions, I suppose, is that this has some very impressive results. 90%, which is very good. Well done. Could I just ask, you mentioned about being a proper trial, evidence-based. There's no control group here. How can you justify that in the standard protocol for a mycosis study?
We talked about this with the review panel. We talked about it with ethics. And we came to the decision that because it was a positive mycology study, every patient presented positive. Because we were going to use active laser on those, my team didn't feel that it was ethically acceptable to then take patients into a program and treat them with a sham laser. We didn't really see that there was going to be any benefits in that. I think in terms of what you're saying, it's very important. We do need to do this again, and we do need to have controls like that. But my whole interest in this at the beginning was, does it work, doesn't it work? I wasn't really interested in proving anything. It's just that that's what we happened to do, and by anything, it was an accident. I think any study, irrespective of what it's on, needs to be repeated. Until the results of a study are actually enforced by another study, as you know, you're just presenting results. I mean, this needs to be taken up by somebody else. Somebody else needs to start researching this now. Somebody else needs to see, using the protocols that we use, is it duplicatable? I'm not going to do that because it wouldn't be right. You might like to do it.
Well, I'm very happy. I mean, and did you not consider doing a crossover trial in a randomized fashion? I mean, that would solve your issue. But the other question, you say you got 90% improvement. You didn't actually say what improvement, what was your outcome measure, your primary outcome measure? Was it on nail clearance or was it on mycology?
We did two. We looked at the nail clearance, how much percentage nail was clear at the end, and we also looked at how much fungus was residual at the end. What we also did was, which we didn't include on this, I wanted to see at which point the fungus was no longer active. So we actually took core samples of the nails at periods throughout this. So we actually drilled with a burr into the nails, and we sent that for mycology testing. And on most of the patients that we had after one laser episode, it wasn't coming back as a positive mycology. So then you have questions about false negatives and all sorts of things, but wasn't going there. My primary interest, as I say, was, does it work, doesn't it work? Can I get enough evidence to satisfy myself? Can I go back to these guys and say, yeah, you might have something that's worth it?
Yeah, because the only final thing which I think is an important point to make is that consistently large high-power studies have shown that fungal nails are damaged first. And so what you have is a dystrophic nail once you've cleared the fungus. And the sort of nails that remain thickened but fungus-free is about 36, 40, sometimes 50%. The clinical cure rate in every other study is about 40 to 50%, which suggests, you know, you're suggesting that 90% of your cohort actual had physical improvement in the nails. Is that what you're saying? I mean, it's not clear because...
Of the patients that we had, everyone that we treated, I would say 60% of them actually had gryphosis, they had thickened nails. All of those patients, their nails were reduced down. At the end of the study, their nails had consistently grown without the thickness. The thickness was less. What we're looking at now is, does the thickness continue to improve? Because what happens with each of these laser interventions, if you have a nail that we've reduced down and it's thickened, you'll actually see stepping in the nail as the nail grows, and the nail is actually growing thicker. We've seen nails where it has been totally detached from the nail bed and we get readhesion to the nail bed. So a lot of the things that we would have seen from the literature and we would have read about in previous studies, in my view, in terms of this, didn't stack up, because we were seeing the nail coming back thinner, we were seeing it adhering to the toe, and we were seeing proper correct growth. Yes, the ones that were extremely thick, they did have slightly thicker nails than what we would consider to be normal, but what's normal for me isn't normal for somebody else. It was normal for them. Now they had nails they were happy with. So I would be able to say and stand over from the research that we had did that yes, the nails do grow back at a better thickness. Do they grow back to the original thickness? I don't know. I didn't see the nail at the original thickness, so I can't comment on that.
Yeah, I think that's the major appreciation with fungal nail disease. It's a secondary event to nail trauma. And whatever intervention you use, drugs, lasers, or anything at all, you cannot reverse the damage previous to the nail and expect the nail to look like it did when they were 12 years old.
I think to say that you cannot is actually ruling out the possibility that you might be able to, because the evidence that I have here would actually rebuttal that, and I would be able to say that I have enough evidence were I to sit down and do this again to say that in most of the cases we saw where it was a traumatic injury that had caused this, where we did have thickening of the nail bed, we now have nails that are growing back consistently better. They have adhered. The trauma has gone. The reason for that, I don't know. We're also looking at the possible reasons for that, because we know what the laser does to the tissue. We know about the cascade effects. We know about the reactive oxygen species. We know about the reepithelialization of tissue. And when you look at that and you look at the subject of trauma within the nail, then theoretically it is possible to say that that event could happen in such a way that the nail would grow properly, the trauma would no longer be evident. We need more research to be able to say that that's there. But at this particular point in my career and looking at this, I'm going to say I don't exactly believe past evidence. Every time we do a new study, we get new evidence. That evidence stands or falls on the next study that's done about it. So really, if we're going to say it can or can't happen, then we need to examine, can it or can't it happen? I mean, I would always have said, things cannot happen, things cannot be so. I looked at this machine and said, things cannot happen, things cannot be so. For many years, I've had tunnel vision as a podiatrist. I've seen what a podiatrist does. That's the tunnel I work in, and I've been unable to look outside of the tunnel. If this thing has done anything, it's shone a very bright light on what I do, and it's shone a very bright light on the way that I think.
So within a clinical setting, when you're dealing with patients who are coming in and are really quite damaged psychologically by their nails, you obviously need to manage their expectations. And whilst we can't say to them, yes, you're going to have normal nails again, because actually that's totally unrealistic, we can pretty much categorically say in most cases you will have an improvement, and for most of our patients an improvement is what they're looking for. They are not looking to have normal nails and to be able to model their feet. They're looking to be able to just not be quite so embarrassed. So you have to look at what your customers want and give that to them, and I think we're doing that pretty well. It's not about can we make world peace. No.
And we
can just make nails a bit better.
Yeah, we don't set out to say that the laser is going to give you perfect nails back. We never set out, and we actually grade infections, and we take photographs, and if somebody comes in with thick fungal toenails, we make it clear that they're going to be better. There's going to be no infection there, but they will be a bit thicker. Yes,
and we also don't treat people. Or I personally don't treat somebody if I don't feel that we can meet their expectations.
You have to manage the expectations.
All about the
I
expectations.
think that's important, and I think the key point to make here is that you're absolutely right. I agree with you 100%. But for a study to say 90% of patients will be cured or better is a very, very large amount.
It's very true, and it's reputable in our clinic, certainly at London Nail Laser Clinic, that over 90% of our patients are getting an improvement in their nails.
So it's an improvement, not a cure, is that?
For some of those patients, it is a cure. For the majority of our patients, without taking cultures, we see that the nail is far stronger. There's no crumbliness. It's not yellow anymore. There are various signs that we look for in clinic, and we reach those for most people, within 4 treatments. We obviously do extra treatments as well if we haven't met those, but there has been some sort of improvement. If there's been no improvement at all, or there's been a deterioration, we won't continue with treatment. We will then look at dermatology. We'll look at other options and see what's going on.
And see, the other thing that we're saying too with this is when we're saying 90%, what I'm saying is this was an 18-month study. By the end of 18 months, 90% of the people on that study had met the outcome. And the outcome basically was they no longer had a fungal nail infection. And that's what we met. Does this work for everybody? No, it doesn't. Do you need to screen your patients properly? Yes, you do. There are other things that we have to look at. If you have an immunocompromised patient, you're going to have to consider what you're doing. So we're having to look for things like methotrexate, Humira, Imbro, Lefleximab, all of these things, and we need to know what's going on there, because a lot of these things, one of the recorded side effects of methotrexate is fungal nail infections. So, you're going to have to think of it in terms of what is right to treat. And I mean, it's like Martina's saying, you need to screen your patients. You need to do your mycology. It's no good to just eyeball it and say, that's a fungal nail infection. You need to have evidence of what you're doing, and a test will give you the evidence.
Yeah, the biggest part of this treatment is the actual assessment. It's managing expectations. It's very easy to put a patient's foot in their 12-minute cycle, but that's only a very, very small part of the actual treatment. It's your role as a podiatrist to really know your mycology, to understand what a nail fungus is, to talk about management for the future, looking at their shoes, even their diet. One of the things we make is important to us is if somebody's got a partner that's infected, we want to treat that partner too, because there's no point treating them. There's so many variables. So your role as a podiatrist is to really do a really good assessment, and then you've really got to manage that treatment all the way through. It's not just about putting your foot in the Lunula. It's much bigger than that.
And see, when we started this study, we didn't have criteria in terms of percentage of infection or percentage of clear nails, in terms of what category they fitted into, how many laser treatments that we would do. Now, we have recommendations that we would say, if you have this much of a percentage, you use so many. What we're basically saying is your baseline treatment is 4. 4 will do for up to 50%. If you have over that, then you're going to have to do 6, and you're going to have to do 8 if it goes beyond sort of the 79–80%. And with some patients who have total inclusion, you may never get anywhere, but you will get a reduction in the thickness, because I think I have patients where we have had very thick nails, and we treated them outside of the study. The nail has reduced considerably. The thickness is gone. The nail doesn't present as fungus on mycology, and it appears to be clear, and they're happy with it. So again, it's back to managing the expectation, but you need to look at it in terms of, if the nail is so much infected, it's 4. If it's over that, then you increase the application.
Thank you.
Any more? Are we getting off light today? Gentleman at the back, gentleman at the front. Lady on the side. Sorry.
Or is it just certain groups?
We didn't look, this study basically looked at fungus that is dermatophyte in nature. So we're not looking at candida or anything like that. We're just basically looking at this particular condition, nothing else. Can it treat other things? I have put other patients into it with other conditions, including candida, and we have got results, but we haven't done a study on it. Will it treat it? It will treat it. How well will it treat it? I don't know.
Right, so there are limitations.
In clinic, we do treat all types of fungi. We treat candida as well, and get some very good results.
And yeasts?
Yeah.
All right,
Yeah.
very good.
Absolutely.
Okay, thank you.
Did you?
In terms of, sorry, have I pinched from?
There's just a young lady up here.
Sorry, apologies. regards the sale of the laser, who is this available to at the moment regards practitioners? Is it just podiatrists, or are they going to be made widely available to perhaps beauty clinics,
No,
etc.?
it's a class 2 laser, so to an extent, if I wanted to, I could, but anybody who launches anything, you know, and they want to penetrate a market and get efficacy with the treatment, any companies who want to be there one day and be gone tomorrow, they'll sell it to anyone.
Yeah.
But if you want to be there for a sustainable period of time, then you have to make sure that you're selling the devices to the right crowd.
Brilliant.
If I was to sell it to
Yeah.
a crowd that didn't have any feet involvement, didn't have any medical sort of background, then they would just be plonking somebody's foot in the laser and off you go. So
Precisely, which is, yes, I felt like all
I
this
think-
discussion in
yeah.
this room would just go out the window, because there
Like
would be
a-
people who would buy that up.
You're totally right, and I mean,
Yeah.
it's like what my colleagues were saying here. You know, you need to understand what you're looking at. You need to understand what you're treating. You know, if you have got a limited knowledge, a limited qualification base, you're not going to know that. And besides, this is something that was developed for the podiatry market. It belongs to the podiatry market. That's where it will stay until we find something better.
Great, really reassured to hear that.
Yeah.
every country is different. In Germany, our market's dermatology. It's the dermatologists that look at onychomycosis, so that tends to be our main platform. But yeah, I mean, one thing we do for anybody who hasn't got experience of actually treating patients with laser, it's not just a case of, you know, there you go, get on with it. You know, we're developing a panel of classes, experts who've got experience in the field that can help new customers who don't quite know their way around lasers and need their experience.
Can I just ask, now that the study's over, if you have somebody coming into your clinic and you're using this as a treatment, do you debride it any more aggressively? And also, so there's two girls on the panel there. I appreciate what you were saying in terms of your study.
Yeah.
You had to kind of try and, you know, keep it within a certain parameters.
I set up a protocol that I use in my clinic. Like, I employ 6 people. We all run exactly the same protocol. The reason we do that is when we were doing this study, it worked for that. It isn't broken for us, so we don't need to fix it. What the girls do may be different.
We debride aggressively.
Thank you.
Gentlemen, just here.
So can I just butt in there very quickly? Do you, in your study, did you use any antifungal creams for the patients? Did they use that? Because that's what we're supposed to do.
Well, we basically, like, for the study, we couldn't have anything else in. Because if we had something else in, it's a case of, was it that product that fixed it?
So
Or was it the laser?
Should one still carry on doing that?
No,
that's-
because like what we would actually do now is every patient that we would have, we would give them an antifungal powder to use as an assist to the treatment, because sometimes you're going to have secondary tinea pedis or something like that going on. And the laser will actually calm that down. But because of the nature of it, it's going to recur anyway. So we would use a powder to suppress that. And what we would have actually found with the study, we didn't do that. Everything sorted out anyway. Now with the patients that we treat, we will give them a powder.
Yeah, you've got to treat the tinea.
Yeah.
You can't. You've got to break that cycle. You can't just do the nails. You've got to treat the skin.
It's just that after we debrided the nail, we've been using antifungal creams, and we gave away a patient tube of Lamisil to use in between the treatment.
I mean, that's fine if it's the way that you treat your patient. And
No, that was what
Yeah.
I thought was supposed to be done. But if it's not, then I'm quite happy not to
we
do
also
it.
give out Lamisil and a few other creams, and the reason that we do it is not really for the nails, it's to just try and eliminate any spores that are on the skin, so any tinea. You know, putting it on the nails, quite frankly, won't do very much at all.
Right.
Putting it all over the foot, in between the toes, under the arch, everywhere, should actually eliminate the spores that are sitting there, and that's what we want to do. We don't want any new spores getting into already weakened nails.
No, because I found that using the Lunula, there was a great improvement in the skin itself.
Yeah, absolutely.
You know, the skin fungus was kind of disappearing very, very quickly, so it was very effective.
see, within the study we didn't, because we were purely looking at the intervention itself. Outside of the study now, what we do is slightly different. Everybody has a powder. 2 of my staff will decide they want to use a Dactarum-based cream or they want to use a Lamisil-based cream. If they want to do that, that's their choice. If they do that, we don't charge for it because they're paying enough, in my view, for the treatment anyway.
Okay, thank you.
You do everything that you can in your role
Gentlemen,
as a
just
podiatrist,
here.
don't you, to treat this infection.
Yes.
I think you said at the beginning of your talk that there were 2,500 days, working days lost due to discomfort. Did you track that across the study as to were most of those early on and therefore following treatment there were less days? Or
when we did our questionnaire at the start, like we had questionnaires that everybody filled out, and one of the things that we asked for was discomfort. And we saw that discomfort was coming up quite a lot, and it correlated with thick nails. When the patient came back again, we actually started asking, did you have any time off work because of this pain? And that's how we got that figure. Across the study, we didn't track it because it wasn't an outcome that we were looking for. It was just something that had starred there, and it was an interest, and it was a case of if ever we had to make an argument to a health insurer for a treatment based on is this cosmetic or is it medical, our argument would be if it's something that takes you from time off work, then it's medical. If it's not, it's cosmetic. But as soon as the nail is reduced, the pain subsides. I mean, the problem that we have in Ireland is people will run around with these things in their shoes for years, and they just get thicker and thicker and thicker, and they get so embarrassed they don't want to come to anybody and see them. They actually come to us then because of the pain that they have. So there are days lost because of things like this, but really it's not lost because of the condition, it's lost because of the stupidity of the patient in terms of managing their own condition. Okay?
The point we always try to get across, because this is the first continent that we've launched the Lunula in, so very much from our perspective it was learning as we went with help from feedback from the likes of Martine, Katrina, Sangeeta and Robert and others. And we've very much tried to put a personal platform together because, you know, if it's bad experiences or if anybody has a negative experience, we all need to know as a group so that we can, you know, have a pathway forward as to how to handle it. So we can pass that on to everybody else who maybe isn't quite experienced when they're starting out, you know, doing some treatments.
I mean, there are things that we found in the study which, if you're treating patients or you buy these devices, that you're going to have happening to you, and you're going to think it's an adverse event or a side effect. I mean, one of the things that happened with us when we were doing this study was patients were complaining of tingling in their feet. And we were thinking, oh shit, it's a side effect. What do we do about this? So we started talking to them. We started looking at the chair they were sitting on. We started looking at the position of the chair. And it wasn't an adverse event from the laser. We had the chair too high, and they were straining to keep their feet in a particular position, and they were getting paresthesia as a result of it. So, you know, there's lots of things that you'll find. Another thing that's very important about this study is I'm not employed by these guys. I don't get paid by these guys. They're a pain in the backside in terms of what they expect you to do. But, you know, everything I've presented you today is my experience, it's my team's experience, and it's just me as a clinic that turns over 3.2 million euros a year saying that we have found something that works for mycosis.
I mean, what is the alternative for these fungal toenails? I mean, the patients that come to us have done the drugs, they don't work. They've tried all the sort of paint-on, lacquers and things, they don't work. Their nails are getting worse, their partner's getting infected. What is the alternative? You know, so these people find us, come and they're looking for a real solution, and we can give them that solution. They have to work very hard with us, and we work hard with them, but what is the alternative? Live with your fungal infected toenails?
And see, the other thing here too, which is important, is we're talking about the patient here. The other thing that's really strange about Econia is if you're out there doing something and you have a problem and you get on to Simon, Simon will send you to me or one of the two girls or somebody who can support the questions that you have. So if you do go away and you buy one of these devices, you're not buying a device, sticking somebody's foot in it, you've spent all this dosh and you've got no support. I get 30, 40 emails every week, and most of them are not saying, I have a problem. They're sending me pictures of what this device has done. So, I mean, if you're buying into this product, you're not just buying into a product, you're buying into a support system, you're buying into something that will help you to help your patients. My clinic, when we started this, was at a stage where we were thinking we're going to have to start laying off staff. My next problem at the moment is how many more lasers do I buy? I mean, at this stage, we're running 2 of the FX pain lasers. We're running a modified Zerona for pain control. We've got a new custom-made device because we're going researching into verrucas and peripheral neuropathy in diabetic patients. So there's a lot going on around lasers, and my clinic has benefited from that, and I hope from what the experience that we're presenting to you, your clinics can benefit in the same way. And don't worry about how do I advertise. Before I came over, I sat down with my practice manager and I said, what have we spent on advertising this product? We spent €1,000 in 2 years in advertising. Because what happens is you have a patient comes in, they stick their feet in this yoke, we treat it, they go away, they're happy, it's gone, we get 5 more patients. So this is something that sells itself. It's just a case of you have to have the confidence in selling yourself. Because we've gone from the stage where as podiatrists we're individuals, we're actually practices, we're actually businesses. And unless as a profession we start looking at ourselves as a business and appreciate ourselves as a business, we're never going to move forward. All of these devices and a lot of the other products that you see here, that's the future of podiatry. What we have to decide as a profession is, are we individuals who look at things and think it's nice and walk away, or are we entrepreneurs who will say, look, we'll give it a go. If it works, great. If it doesn't work, you got stung. Get over it.
Just to say that, can you hear me?
Yes.
My name is Sullivan and I have a practice in Bristol, and I'd like to thank Martine and Simon. I first worked with Martine at the London Nail and Foot Clinic, who really helped our practice along, and we worked very closely with Martine. She got us started, and then we purchased our own machine. And I'd just like to say for anybody who's actually thinking about does Lunula work, we had the ups and downs of yes, does it work, and managing our patients' expectations was most definitely one of the most important things to achieve at the start of treatment and during the treatment. And we've probably we're in the process of treating about 100 patients, and I can wholeheartedly, as a private practitioner, say although we had our teething problems, we are seeing really excellent results considering how difficult fungal infection of the nails is to treat. And we have something available to the profession that will significantly improve the nail conditions that many people have had to just live with, because what was previously available to treat wasn't working. So although we're probably a year into treatment, we've yet to come out the other side and fully see all the evidence that Robert has achieved. So, but I'd like to say to anyone who's thinking about, do get in touch with Simon, because it's really exciting. Thank you.
Can I just say on that, over 100 years ago, the Wright brothers were told, you'll never fly. I flew here. We're being told now at the moment, you can't treat fungal infections.
Yeah.
This is my airplane.
Yeah.
Anybody else? Because we're pushing the time.
Yeah, I've got a bit of a technical question, because sometimes we do use this particular laser to treat the fungal infection in the fingernails as well. On the back of this laser, actually, however, I noticed that there was a sign that it might affect your eyes. Would you recommend some sort of because obviously when you treat the toenails, it doesn't matter. For the fingernails, you have to bring the laser to the level basically a bit higher. You can't just lay your patient down.
Okay.
So, yeah,
initially when we started with this, yes, we would have said you need to wear glasses. Because it's a class 2 laser, any class 2 laser, you're supposed to wear glasses. When you look at this in terms of research and the light scatter patterns and everything else, the way that the device is constructed, everything is contained within the box. Unless you're physically going to stick your head in the box, you're not going to get hit by the scatter patterns. Because if I put this on, and you run it, and you actually look at where the light is, no light comes out onto the step.
I'm not talking about myself. It's more kind of because when you have,
when
you have a patient sitting like this in front of the laser, you have to concentrate on.
I would have them sitting.
Or it doesn't matter.
Yeah.
But you they will look at the laser one way or another. So my concern was
just
to protect ourselves as well, because I don't want
an issue.
Patient to come back later and say that I caused him glaucoma or something.
No, it's not an issue. It's not going to do it, because I mean, we use lasers on eyes every day, and it's not going to create a problem, because you're talking about a frequency which is quite low, and it's not going to irritate the eye because it's not there for long enough. And it's below, even if you're treating hands, you're going to have them on the table, so you're still below it. And yes, you can look at the light from any direction, but it's not going to, I mean, with all the patients that we treated, we have put patients through with hands. We've never had anybody say anything. I've looked at the literature, I've looked at the research. A lot of the literature and the research around this, some will use goggles, some won't use goggles. Do I use goggles? I don't. Do you need to? It's a personal choice.
There are goggles in your clinic if you want to use them.
That's why I use them.
Yeah, good.
Can I just ask, those who use the Lunula, metal plates and things in the foot, could you still use them?
Originally we would have said no,
right.
But now after research we say yes.
Okay. And what about patients on aspirin?
Yes, it's fine.
Yes,
Because I know warfarin is...
no, it's fine.
It's fine because you haven't got an open wound. Right. So, you know, it's just more blood going
I found that by using the Lunula on patients who were on warfarin, I had one, there were micro bleeds in the area, so that did concern me a little bit.
If we're treating somebody with warfarin, we would always look for their INR reading.
Right.
And if they have a stable INR reading, and it's under 2, 2.5, you're fine. I wouldn't do it over that. If they're taking aspirin and they're taking the standard 75 dose, you're fine. 100, I wouldn't. Not at the moment.
Okay, thank you.
Okay. Are we done? Thank you very much.